So, and then remember that pharmacokinetics is what the body's doing to the drug, and pharmacodynamics is what the drug is doing to the body, so to speak. He is the only one lit up. Who? Me. Right. Okay. So somebody must be getting an echo out there, and I don't know why. Okay, Michael, the next one, please. You also have to have basic ideas of adverse effects associated with the drugs, what we would call the side effects. Now, black box warnings are absolutes. Okay, everybody knows what that is? Yep. Anybody not know what a black box warning is? Nobody? All right, good. I'm glad I don't have to go over that then. Okay. You need to look at the contraindications, drug disease indications, interactions potentially. Not just drug-drug interactions, but also drug disease. So, for example, if you have an elderly person, you decide to put on Cymbalta and they have a history of glaucoma, is that a potential problem? Yes, it is. So you don't do that. It's a contraindication. You're not supposed to do that. It's not a black box warning. So in terms of the atypical, what is the big black box warning with atypicals and elderly? Do any of you know? What kind of death? There's two types. Really dead. That's very good, Tommy. I like that. Cardiovascular, that's one, but you mean heart, right? Or are you talking about broader? Heart and stroke. Yeah, heart failure and strokes. You increase the death rate. It's not monumental. I believe the actual figure is about 1.6 increase in odds. What is the black box is sort of wrong. Like SSRIs increase suicidal thoughts, but not behavior. Are we going to see test questions on that? I'm not sure every antidepressant has a warning that it may increase suicidality. I'm not sure that's a black box. I don't recall that being a black box. There was a period of time for the pediatric cases that you were committed to telling the parents that there was a high suicidal risk, but they also came out with the idea that you were supposed to be seeing the patient once a week for 4 weeks because the risk was early in treatment. Now that's lessened a lot, and I'm not sure for adults there is a black box warning. I don't think there is. Yeah, under 24 or over 65, right. Right. So you're still there, I guess, for young adults. But you, as a general rule, you're still supposed to be going through the side effects and telling them that could be a potential risk of suicidal thoughts. But with the children, the problem that was occurring was mostly due to some misunderstanding, and actually for a period of time, they stopped giving kids antidepressants, and there was an increase in suicidality among kids. So they backed off of that a little bit. Hippocrates still has black box warning for Prozac about the suicidality. I'd have to make sure that's correct. But you're never harmed by saying it, so you could just assume that it's going to be out there. But not for an adult. Just looked it up. What are they saying? Children, adolescents, and young adults. Okay, that's it. That's still out there then. Should we be saying suicidality or thoughts? It's just thoughts. Can this be asked as a pet question? Yes, it could. Yeah. Remember, it's always being safe. That's when I saw a black box. Okay. It's all about being safe. So if there's a question that has some potential issue, like committing suicide, obviously, that would be a bad outcome, they're going to try to come in there with a question like that. So they're looking for that's the level of knowledge you need to be at. All right, so what else we got? Significant drug-drug interactions. Now, one of the problems are, any of you, I know Jessica is now, but is anybody out there on EMRs? Some of you are, but you're not currently writing prescriptions, right? Right. Unless you're in the military or something like that. Step 2, you're writing prescriptions, or are you saying yes that you're on EMR? Okay, Anthony, you're writing prescriptions and you're on the EMR? Is that true? Correct. Okay. Now, Anthony, are you aware of when you write that, when you're ordering a prescription on the EMR, you're going to get a list of all drug interactions? Isn't that true in your system? I don't know what system you're using. Okay, that's correct. But has it been your experience that most of it is theoretical? Often inaccurate. They're not. You mean by they don't occur, right? Is that what you mean by inaccurate? Some error as well. Yeah. And the real problem with that is that most of it, from when I look at them and I read them carefully, they're 90% theoretical. And in many cases, if I'm seeing an elderly person who's already on a lot of medications, they're listing all of these potential interactions. Some are red, some are yellow, some are green. You know, and then some are just plain print. We have this system that sort of flags them in terms of the color means real bad, red means stop, don't do it. But they're already on the medication. They're already they've been taking it for a long time, and it's in the same medicines that have been there supposedly interacting have been there a long, long time, and they're not interacting. So whether it's an error, or I think it's just this sort of theoretical idea that you could have this interaction. And that's the way I look at it. So if the patient's already on the drugs, and I didn't give them that drug, am I responsible for it? Yeah, you're still responsible for the outcome, unfortunately. So then you really want to know how long they've been on and whether they've been taking it regularly. Okay. Maybe this is why some of the family practice docs in my area are getting more unwilling to prescribe some of the meds for psych diagnosis. That's probably true. That's probably true. Plus, you know, they don't have the best of training and all that. They're not really, they got other things they got to keep up on, not all these psychotropic medications. You know. It's like, you know, if I were to ask you, any one of you, do you think that bupropion is a good drug for somebody who has anxiety? What do you think you all are going to say? No. Okay, no. You know, it's more likely to generate more anxiety because it's an activating antidepressant. So, you know, it's not out of the realm to think maybe one patient out there might do well with it, or several that you might run across the course of your career. But as a rule, that's not like something we would reach for. That's just not our first go-to drug. We're not going to do that. And I'll get cases where somebody's, you know, putting them on a high dose of Wellbutrin, and then you're finding they're not getting any better, they're worse, and that's why they got sent to me in the first place. And so my first move is to take them off and try to get them on something like an SSRI, just depending on what it looks like. But that's the kind of stuff, and I don't fault that person because I don't expect them to have the expertise for these drugs. That's our job as we take this task on. We're supposed to know. And I think they appreciate the help. And other people who criticize family practice docs, I think that's just fundamentally wrong because I think they're trying to do the best they can. Let's see. Next step. I think we're, wait, could you go back one more? I'm sorry. Okay, clinical monitoring, these are things you have to decide. Do you need to do any kind of therapeutic drug monitoring before you actually give the drug? You have to decide how often you're going to do some other lab test. You may want to get some drug monitoring levels, but mostly you're going to be concerned about side effects. Remember this, lab tests can be easily ordered, but they're costly. They're very costly. So you have to be mindful that you can't just go willy-nilly ordering tests every time you think. You always have to have a rational reason for why you're doing it and why you're doing it at this particular moment in time. Okay. Therapeutic drug monitoring, TDM. Be like we're monitoring a lithium level. Okay. Let's see. Next one, please. So here's you want to know, okay, what are the most effective treatments for schizophrenia, bipolar, depression, anxiety, ADHD, and substance abuse? Those are the big ones they're going to ask you about. Now, there are going to be some little things here and there that I may miss, but these are the big ones, okay? These are the big ones. So make sure you know what the most effective treatments are. Kind of what we were talking about in some of those sample questions. And by anxiety, it's all anxiety category and all depression and bipolar 1 and 2, that type of thing. And ADHD and attentive, not otherwise specified, or hyperactive or mixed, whatever you want to call it. And of course, substance abuse for all of the major drugs that are abused. Certainly alcohol, right? Even stimulants. What else might you be thinking about? Especially nowadays with the loosening of opiates. Sadly, what I see is a lot of what is prescribed is drug-driven, representative-driven. If you want to know why, how they do that, Laura, why they do that, it's not just because they get a little donut or something. It's because you're given samples. You're given samples in abundance. And then they have coupon cards to reduce the cost of some of the drugs. But initially, you get all these samples. So you have an opportunity to try something out. Unfortunately, the first person you give it to is your guinea pig, okay? And as we all know, is there any evidence that says that one antidepressant is better than another? Now, I'm not talking about for the individual. I'm talking about as a class. Yeah, but then if you give it to somebody who doesn't have insurance or money, now you're obligated to continue giving it to them, and if it happens to work, that's great. But you're going to run short of samples, because that happens. I can tell you that it happens. So it's one of those, kind of things that you have to sort of think about. You know what it costs to get Abilify? I mean, 15 mil. Does any of you have any idea what it costs if you're going to buy Abilify as an and you're going to use it to augment somebody with depression? You have any idea what it costs a month? Not quite that high, Christine. It's more like $600 to $700. Very good. Yeah, it's in that price range. It's ridiculous. Most people cannot pay for that. So, you think the drug companies are happy to order that? Not the drug companies, but the insurance companies? Yeah, the drug companies are happy to order, but they can't order. They give it to us and we can pass it out. But in terms of what does the insurance company do? They're going to deny it. That's exactly right. Now you can do you can do an override. There is a way to get it done, but you better be prepared to deal with the issue that if this was your first attempt at augmentation, they're going to want to see some failures on some other augmentations before they start putting out that kind of money. Okay? And like I said, if you started them with the samples and they're doing well, now you got a problem if they get denied, and then we have to get what we call prior authorization to do it. It's going to be a problem. So you have to think about that. But the samples make it easy to give to the patient to try, and it looks like it's for free. And I tell patients this: if the doctor's giving you samples, you can bet it's one of the most expensive drugs. They're not giving samples for generics. have to follow step therapy where I work unless there is no generic availability. And then where you work, is that like an HMO, or is it a government facility of some type, like the Veterans Administration, Kirk? It's Intermountain Healthcare. It's okay, nonprofit. Okay, that makes sense. In any of the community mental health centers, they have to do that here in Louisiana. But private other entities like our clinic is, we can do whatever we want. No one tells us what we can do with that stuff. What is step therapy? It's a preordained pattern of choices, if you would. So it's this drug you start, or one or two drugs, and then you follow a sequence, like a flow chart. Algorithm is another way of saying it. Yes, Pep2, that's exactly right. Generics, the chemical has to be the chemical, right? So we all agree with that, right? You can't say here this is duloxetine and it's not duloxetine, it's amitriptyline. You can't do that. So you have to give the actual drug, but then the pills are proprietary. The company that makes it has proprietary ownership of that particular pill. So then it becomes incumbent upon a generic company to come up with something that's equal. Now, they all have to be roughly bioavailable equivalents, meaning the amount of drug that you're going to get into your system. But what it does affect, roughly means 20 plus or minus percent. So meaning you could be 20% higher in terms of the amount of drug you're getting in the system, or 20% lower. So that's like a 40% variability there, if you would, based on a formulary. Generics have different fillers based on a formulary. What do you mean, Laura? Oh, bad. Okay. Yeah, the STEP program is like a structured way of doing it. You have to go through a set of choices. It's already preordained, as opposed to you choosing whichever your favorite drug is for that particular day. Okay. And most clinics that are controlled by government money or nonprofit, they have very strict guidelines. They try to take control of that because because of the cost issue. And once again, the newer drugs are not necessarily better. And if anything, that's what we've learned from the atypicals, because everybody thought, oh, the atypicals are going to treat the negative symptoms of schizophrenia. Turns out they didn't do much better than the other drugs. Maybe a little bit better, but not a whole lot. Do I ever write brand necessary? Yeah, sometimes I do. If I have a patient who's rather brittle and they stabilize and this issue comes up, I try not to change it, so I'll put brand necessary. The pharmacists get incentives too for doing certain things. They like you to use the generics in some pharmacies because they get some bonus money out of it. So you always have to sort of look at those kinds of things. Cost, to me, is a major factor in psychotropic medication. Because if a person can't afford it, it's a useless drug. It's just not going to help them. So you have to think about that all the time. And I know some people that wouldn't even give it the thought of day. And that's sad. Because in the end, they don't take it. And a lot of patients won't tell you that. Because they're embarrassed, or they feel ashamed, or they tried it and they just couldn't afford it and they didn't want to admit they didn't have the money. Some will come right out and tell you, I can't afford that. And that's good. But I always ask. I just try to find out. Okay. Let's go on. I think, wait. Yeah, okay. What is the most efficacious, safest treatment, best option? What psychosocial factors are important for adherence? That's pretty obvious. Promoting optimal functioning and minimizing relapse. That's stuff you need to kind of look at. And next one, please. Let's go to 8. It's been an hour already. My goodness. These are those studies, and this stuff I went through. That's why I recommended that second chapter, because I was looking at that in Muse's book. I thought that was a reasonable thing. So they had these various types of information related to the meds versus CBT versus interpersonal therapy for different levels of depression, and that's the STAR-D, and then you have the children's one, which is the TADS, and then there's an adolescent one, which is the soft tabs. So just kind of knowing that, and that chapter does summarize that stuff fairly well, describes the studies and summarizes. So if I was you, that's a valuable chapter because you don't get that anywhere else. That's why I recommended it. Do you ever write? Okay. All right, let's go to the next one. Oh, these are the algorithms, and that's from that chapter as well. And let's go ahead a little further. And okay, and then we go into neuroscience. Okay. Here's what you got to know. Be able to tell basic general principles of neurons versus glia cells, the types of glia cells that are out there. You got to understand the action potential well, so you better be able to map it in your head. They're not going to show you a figure, they're going to describe something. Differences between ionotropic and metabotropic receptors. I identify the common second messengers. You want to know the neurotransmitters, the biogenic amines, the amino acids, nitric oxide, which is a special type of transmitter, and neurotropic factors. And you really want to know these. This group here, I don't know if I can point the, I guess my pointer doesn't work, does it? I don't think it does. All right, we're back, right? So now I have control. All yours, Doug. Chapter Muse said TMAP was too outdated. That's probably true. We need to know MOA. So you're saying method of action, is that what you're saying, MOA? Yeah, okay. Yeah, I think I put that there. That comes down here lower. I'm sorry, I'm coughing. I'm trying to drink some tea to make this go away. Okay, so in terms of hope that doesn't happen again. I'm sorry. Coughing. So we get back to the neurotransmitters, the biogenic amines, the amino acids, the nitric oxide, neurotropic. I think we talked about, but these particular neurotransmitters you have to really know. You have to know how they're synthesized. Boy, it's going to stop soon, I hope. And how they're degraded, how they're broken down. You need to know the pathways. And early on, I had some access to it, PEP-11, but I haven't looked at it much since. Okay, the nature of the questions are different, though, for the PEP. So you just need to know the pathways for how these are formed, how they're broken down, And then, of course, the receptors, what they do, what they actually do, okay? And whether there's any pathological implications. And you can get that information from the Clinical Handbook of Psychotropic Drugs. Okay. When you say older drugs, what are you talking about? You talking about the tetracyclics or the old antidepressants? Are you talking about the old antipsychotics? Oh, TCAs. I'm surprised. That would be. You sure? You know, the ones that I would think you would see, if you're going to see any, is nortriptyline, amitriptyline. Not much beyond that. Maybe doxepin, but I wouldn't expect you to see all of those other drugs. I'm surprised. That's not the way it was for me. The only thing that they would tell, the big issue about TCAs would be something like QT prolongation, looking to see if you understand that there's a risk of cardiac failure. That would be a question that if you were going to ask anything about the TCAs, that would be one of them. And whether you're going to give them to certain elderly people because of the anticholinergic properties. But we can talk about, we're going to talk about those anyway later today, so we'll cover those a bit. I don't think you'd be, excuse me, I don't think you'd be disadvantaged by having the 19th version simply because, again, any drug like Vibrid would not be in there. Okay, anything relatively new in the last year, maybe even year and a half, you're not going to see it. If you're a 19, okay, yes, I'm sure I get those, but also why you would use them. I mean, in terms of what you would treat them for and what they're approved for. Well, when you go through what I said in the beginning, you'll figure that out, why you would be using them. Because again, if it falls down to picking medications, which one you're going to do, you're going to look for side effects, you're going to look for harm, and then you're going to say which one's approved versus which one's not, and that'll get you where you need to be. You have to know the rate limiting steps. They ask that. So for each one, you should know the rate limiting step. Yes, that's why your study guide is so great. Yep. That's what you got to do. And look at the receptors, okay? They get a little confusing, but they do want you to be able to identify a few receptors, like whether it's an autoreceptor or not, that type of thing. And then some of the putative kind of theory about what this is actually doing, how it works. And again, in that little chapter, in the clinical handbook, there's a page, actually there are 2 pages, for each category, particularly for the antidepressants. You can see this where they list, and the antipsychotics, they list out the receptors, how they're being affected, and then what the clinical implication is, okay? So for instance, if anybody has the 19th edition, what I would tell you to do is to go to page, let me find it for you, right here. It'd be page, no, that's not it. Here it is, page number 57. Some of you have it. You can look at it. And what it's showing you is the mechanisms in terms of how much they do such a thing. So, for example, when you look at the muscarinic blockade, you'll see that there are a lot of pluses. The more pluses, the more likely is going to do that. Okay, the less pluses, so bupropion really doesn't do that. But if we look at something like amitriptyline, you're going to see that they have significant anticholinergic effects. Okay, But when you go back to if you look at the opposite side of the picture, I mean of that page, you go to 58, you'll see that it'll list the MA, which is the muscarinic receptor for acetylcholine, and it's telling you like second most potent action of cyclic antidepressants, the older cyclic ones that we're talking about. The side effects are eye, mouth, or vision, constipation, urinary retention. Knowing that tells you something about what might happen with a person who already has urinary retention problems, or somebody who has some QRS problems. You might prolong that. And memory loss, you can create memory loss with it. So this sort of puts the receptors in your mind properly, and then what it does, okay? And that's important. So it's worth having to look at it, and it reminds you why you're not doing it or doing it. Let's go on to the next page now. So when you look at the anatomy, you want to have a basics understanding in neuroscience with regard to the brain's lobes, which isn't that complicated: frontal, temporal, parietal, occipital, cerebellum, and limbic systems. An idea of kind of what they do, basically. You can find that in your book, the psychiatry book, because they go over that a bit. And they have these different types of mesial frontal issues and lateral frontal issues, and it's some interesting stuff. The dorsolateral stuff is associated with some cognitive difficulty, that type of thing. And mesial is associated with kind of a withdrawal and lack of abulia, so to speak. And then there are a bunch of other things that can happen with the orbital area. But in any case, they give you some basic ideas of what kind of pathology you would see there. The basal ganglia structures are really important in the diencephalon. Really, in terms of the diencephalon, you're going to be more concerned about the hypothalamus. What does it do? The releasing factors in the anterior and posterior pituitary, and dopamine and its relationship to prolactin. Prolactin is obviously an issue because it creates what? Anybody know? If you have too much prolactin. Yeah, well, not a male won't lactate, but they'll get breast enlargement. Females will get breast enlargement with lactation. Gynecomastia, right, exactly, okay. And dopamine acts as what? Why does it, when you, okay, yes, that's exactly right. It's acting as an inhibitor of the prolactin release, exactly. So if you give a D2 agent that's a blocker, now you're losing that inhibition. Okay, and then so pay attention to that. That's a big issue. It'll come up, I guarantee it. And then the releasing factors in the anterior posterior. You might look at the structure of the hypothalamus just to remind you that there are some satiety areas, and there's problems with people overeating and issues related to food consumption in general. There's some structures that you want to pay attention to. And then the reward center, the septal area, or the Cuban's nucleus, that type of thing. So you might want to get into that limbic structural system with the hypothalamus. The vascular structures, they just want you to know the main arteries. And of course, every one of you should know what the artery of strokes are. The principal artery that's likely to show a stroke, is it the anterior, the middle, or the posterior cerebral artery? Anybody know? Somebody should know out there. It would be the, yes, not the anterior. The anterior communicating is a place where you'll get aneurysms that oftentimes pop. Usually you'll die from that because it's a subarachnoid hemorrhage. And most people don't survive it, but occasionally they do, and they have terrible amnesia afterwards. Yeah, so there is the widowmaker. That's a heart, though. That's a heart-related issue. Okay, and so just get an idea of, you kind of ask yourself what kind of stroke properties would be evident with the middle cerebral artery stroke on the left side. You're going to get aphasia for sure, that type of thing. just really kind of simple. The right side of the body is likely to have a paralysis. Okay. Yeah, MC artery is always more frequent than any others, or just creates more damage, more frequent. That's why we call it the artery, the stroke artery. Most commonly, it's going to be a middle cerebral artery. But you're going to see if you're in a clinic like that. Yeah, we haven't gotten there, but we'll get there with the cranial nerves. So I'll talk briefly about that too. So pain pathway, you know, what opiates receptors are out there and where they're aligned. There's a good chapter in the book on the psychiatry update on pain, so that's everything you need to know there. The autonomic system, really we're talking about the parasympathetic and the sympathetic, right? You got to know the receptors, you got to know kind of what they do and like a beta 1, what's beta 1 associated with? Anybody know? It's associated with the heart. You all learned that mnemonic. Beta 1 is associated with the heart because you only have one heart, and beta 2 is associated with the lungs because you have two lungs. Anybody heard that before? Nope, but you heard it now. Yep, there it is. I knew somebody had to hear it. Okay. It's just simple ways to remember what these receptors do because those things come up, okay? Let's see. From a PA. Peter, from a PA. Oh, physician assistant. So let's see if there's anything else. The receptors, the neurotransmitters, and symptoms. That's that basic stuff that you really need to know. It's obviously associated with panic attacks. Sleep architecture and some of the pathology associated with that, we'll come across that again. But there's an article in here. Again, there's another article within that board certification that talks about sleep and the sleep disorder. So you really need to read that. It'll give you all you need to know. Now, in terms of pathology, we're looking at structure, symptoms, and treatment. That's all three, right? What's the pathology? What are the symptoms? That type of thing. And so we all know that there are lots of dementias, but the one we hear the most about is Alzheimer's because it's 65% of all dementias. So that's the one that's the most popular. People think it just got invented in the last decade or so, but it's actually been around. I believe it was in the 1800s, late 1800s. Then there's this vascular. There's a frontal temporal dementia, which is very much like an Alzheimer's dementia, except that it has generally much more personality changes, that type of thing. And then there's Lewy bodies. There's one discriminating factor that helps you figure out whether it's Lewy bodies dementia. Anybody familiar with that? They almost always have visual hallucinations. Okay, but people with Alzheimer's, advanced Alzheimer's, do get visual hallucinations periodically. But when they're more prominent early in the disease, then you start thinking it's Lewy bodies. There's age-related dementias. They want you to know some things about that, so look into that. And again, you're going to find all that in your psychiatry update board. Okay. The PEP study guideline, when I think, I'm sorry, I don't understand what you're asking. Oh, on the list of PowerPoints, one are you on now? Yeah, PEP study guide, that's right. Okay, great. And you know, the role of the APOE is sometimes the PEP patterns that you would see with an Alzheimer's disease is different than that of a frontal temporal. For those of you that don't know it, it's related. If you're looking at Alzheimer's disease, you have involvement of the parietal and the temporal lobes early on. That's what you'll see. That's one of the ways we can differentiate between the frontal temporal dementia, which is going to involve the frontal region largely, and the temporal region secondarily. And that's why you get a lot of behavioral stuff with the frontal temporal dementias. And all dementia, you know, when we think about Alzheimer's disease, what's the biggest predictor of Alzheimer's disease? Somebody out there should know. Age. That's absolutely right. Jessica knows. Yep. All right. Age. It's age. The genes play a role. in terms of your risk. But if you were to say what's the biggest predictor for getting it, it's simply age. But there are familial sources, and it comes down the mother's line, by the way, more commonly. So drug-induced mental impairments, anticholinergic symptoms, medications. So we do get this. You get a delirium with somebody that has that's been given an anticholinergic agent, which could be an old TCA, right? Like a lot of amitriptyline. You can get substance-induced types of things, so they'll want you to know about Wernicke-Korsakoff syndrome, so that's one. These nutritional things, B1 and B12. B12 is real important. It's cobalamin. It's really important for memory, extremely important. So it's always done when somebody comes into our clinic that's older and there's a question about the onset of dementia. We're going to check these 4 things out routinely. There's also, you can get what's referred to as metabolic encephalopathies like renal disease, hepatic disease, diabetic ketoacidosis. You can get this porphyria. There are endocrine disorders that can present as sudden changes in cognitive abilities and behavior. So most of the time when you're working up somebody for any form of dementia, you're going to run a lot of studies to rule things out. They rarely tell you anything, but occasionally they do, and because of that, they have to order these tests. You also want to know your movement disorders, because that will be asked. And not only that, if you look at the clinical handbook of psychotropic drugs, there's a nice chart in there where they're talking about these movement disorders that appear with the antipsychotics, and they lay them out in terms of when they occur, at what stage in the treatment versus how intense it is and how long it typically lasts, that type of thing. So there's a chart in there that explains it all to you, and it's a nice chart to sort of put down for one of those things you want to kind of memorize. They're not going to show you a graph, but it helps you understand how to interpret this stuff. But then those are medication-induced, like the dystonia, the akathisia, the akinesia, the tremors, and then there's this tardive dyskinesia. Huntington's disease is a movement disorder. Parkinson's disease is a movement disorder. Wilson's disease is a movement disorder. Anybody know what the Wilson's disease, the basic pathology of Wilson's disease is? Try to dig back from some of those neuroscience courses you had a long time. Right, copper accumulation. That's exactly right. See, smart people out there. Rest versus intention tremors, lithium tremor. You need to be able to identify a lithium tremor. So what's characteristic of a pathological amount of lithium? What's this tremor described as? Anybody know? Because that's likely the way they'll present it. They're not going to ask you what kind of tremor this is. They're going to basically give you information, and you have to. The resting tremor is a Parkinson's disease, so you can sort of get some of that resting tremor. But the more important point is that is it fast or is it coarse? You know what I mean by coarse? It's coarse. Yeah, it's coarse. It's normal for somebody on lithium to have a fine tremor. An intention is when you're sticking your hand out in the air and spreading your fingers apart and holding it. Another way of thinking of intention is you're intending to do something with your movement. And we're typically identifying them in the hand, so we could see it when somebody's trying to write, okay, or when they're trying to complete a circle or a spiral design of a circle, round and around, that type of thing. Let's see what else. So just be aware of those and familiar. They're not going to be real sophisticated questions, but they'll be pushing it a little bit because they want to know that you can identify these types of things, which makes sense. There are these demyelinating disorders, so you should be a little bit acquainted with them, the multiple sclerosis and ALS. The strokes, here we go again. But I put in the basilar strokes as well. That's and The seizures, you've got to know the difference between the general and the partial, and then there's these absence seizures versus ADHD, and the EEG pattern. And if you look at that chapter, you'll get all, in the book, again, the update board, you get all you need. There are these toxins out there, lead and carbon dioxide and mercury. You probably won't see anything with mercury or lead. I don't even think you'll see a toxin, quite frankly. I'd be surprised. The sleep disorders, the PLM, restless leg, periodic leg movements, PLM, restless leg, sleep apnea, which can be obstructive or central, medication effects, and treatments and symptoms, okay? How the medications can make it better or worse. Neuroleptic malignant syndrome is really important to know, and the CPK is helpful, and the leukocytosis with it is helpful in determining that versus the serotonin syndrome. And then there's malignant hypothermia, which is not a movement disorder, but it gets confused with neuroleptic malignant syndrome. Periodic leg movement. And in the chapter on movement disorders, it's all there for you. I should be getting some stock in this book. I keep pushing. Okay, I'll go on to the next one.